So when you're doing your biomechanical assessment of a patient, for the mid-cervical spine, we'll look at side bending. So we'll have him side bend to the right and side bend to the left. If we notice that there was a restriction, we would go into extension and side bending to see if it was restricted on one side compared to the other, compared to flexion, side bend, side bend. The extension side bending's closing on this side. The flexion and side bending is opening on this side. In NIAMP, we use the term IMP and SAL, inferior medial posterior or superior anterior lateral. That's for the unilateral joint motion to give the 3D representation. It's mostly superior inferior with slight M and P and A and L. But if we continue with opening closing, knowing that that's a three-dimensional reference, that'll work out fine. We would do our PIVMs and say, okay, let's look at the upper, like C2, C3. I'm going to have him side bend this way and side bend this way. Then I'm going to extend him, side bend this way and side bend this way. So when I have him in extension, blocked here, moves well here, but he feels it more on this side. So what's happening is he's blocked at C2-3 on the left, and on the right, it's borrowing range because the left isn't doing its job. So then what we want to do is go ahead and have him lay on his back, and we can try to see if we can get that moving through a manipulation. You could do graded mobilizations, and typically what would happen is if you were working with the painful joint, some schools of thought would say, well, you have to calm that down, so you need to have them in prone and do unilateral PAs, grade 1, grade 2 on that side. The next level of your reasoning is, 1, we're going to address posture. We're going to talk about that in a little bit. But number 2, you want to find the joint that's painlessly hypomobile and see if you can mobilize that, because the hypermobility, or the joint that's moving too much, is typically moving too much because somewhere along the kinetic chain, somebody isn't doing their job. So if we've done the stress tests, what we can do is we can do a locking and manipulation on this side. As long as he doesn't have an upper cervical instability, I can do something called a craniovertebral lock. In reviewing craniovertebral locking, we just want to make sure that we lock up the upper cervical segments, and we do that through a series of side bending and rotation. If I'm trying to get the left joint into extension, C2-3, to extend better, or a better imp, or a better close, then the side bending would be initiated on the left. Craniovertebral locking means I would use left side bending, right rotation. So the quick way to do it is just to take up the slack like that. When you're learning to do it, what you want to do is get your thumb right around C2. When I side bend my head towards, C2 will move away from me. And then, so when I rotate away, it'll move back into my thumb. So it'll move away from my thumb, back into my thumb, away from my thumb, back into my thumb. When I do that enough, you'll feel the upper cervical lock. So when you do it for a while, it just turns into one quick motion. But as you're learning, you just want to take it segmentally like that. Then you can bring your hand in, get your hand right on that C2-3, and then your lock from below will be translation away. Because if I translate to the right, it's going to be side bending to the left. There's no complications above and below, so I did the craniovertebral lock. I bring in the extension. I've done the translation, and I can get right to that segment. And then I could do the manipulation, like that. So the craniovertebral lock just takes out a lot of the extra motion you'll get from the upper cervical region. Then you'll be able to lock it in and get yourself into a position where you can do the manipulation. And I isolate it to the upper cervical spine. So I side bend towards and rotate away just to lock up the upper cervical spine. I'm doing an imp or a closing manipulation, C2, C3 on the left. I've already confirmed that in sitting, but in supine, if I go and translate and try to extend, he's blocked, and on this side he moves well. On this side, he's just stiff. So that's the joint that I want to work on. I take my hand, I bring it along the side here, and I'm holding him in a comfortable position. This hand is on C2, and it's going to do an imp motion. So without doing any locking, that's what I want to produce. That's a little sloppy. So if I side bend him towards and rotate him away above C2, C3, extend him, translate him, now my lock is more solid. Then I could do the manipulation this way. So basically, we can have him in that position, and through doing this side bend towards, rotate away, we lock those ligaments up above. So it's just a craniovertebral lock, meaning from CO, C1 and above, we're locking. We do a translation in order to lock the lower cervical spine. Because if I push here, there's all this motion. If I translate him, less motion. So we're just locking up the lower cervical spine in order to get that more stable. So I'll have him in this position here. I'll find C2. I'll get my IP joint on C2, knowing I'm going to have to push down. I lock the upper cervical spine by side bending to the left, rotating to the right. I extend him to that segment, and I translate. And once I get him to that point where I feel it's comfortable, is that okay? Mm-hmm. I'm going to do a push. So you can do a push and see if you can get the manipulation. So without talking, that's the manipulation. Then I can do some muscle energy. Side bend your head to the left for me, please. Good, and relax. Side bend. And relax. Good. Side bend, nice. Extend and side bend. So now, and again. So now he's moving. We didn't get an audible, and I'm not worried, because joints can move parallel or perpendicular. If you get a perpendicular glide of this joint at 45 degrees, so if I, instead of going in an imp direction, if I had gone straight across, you might get a pop. You're distracting the joint. I chose to push C2 down, which would be gliding it this way, so you might not get a distraction, so you might not get the cavitation. That's fine as long as you recheck your motion, so go ahead and have a seat and go ahead and side bend. So he's picked up some side bending. Side bend to the right. Side bend to the left. So definitely he's picked up some side bending. And then if I extend him and side bend, he's moving better. So now I have to keep him moving better. So we go back, go ahead and have a seat. So it was left side bending. So that I get on C3, and I'm pushing C3 up into C2. Good. Turn your head into me, please. And relax. And then I'm doing that, pushing C3 up into C2. And again. Good. So I neuro re-ed that area. Give him a towel and have him work on that rotation to that side. That rotation there will help that pain there. If you don't feel comfortable doing a push, do some muscle energy in supine, or start with this technique and see if that will free up the glide for the joint. So that's one way to address C2-3.